This is SVT. It's one of the first rhythms everybody learns in ACLS. And there are a surprising number of ways to treat this rhythm. We've got vagal maneuvers, adenosine, beta blockers, calcium channel blockers, electricity, and very few people agree on what to use. According to this poll, 46% of you like adenosine. Not my favorite, and I'll explain why. But how do you actually choose between these treatments? Why can adenosine only be used if the rhythm is regular? And how do 5 different treatments, ranging from electricity to blowing into a syringe to drugs with totally different mechanisms, all terminate the same rhythm? The answer to that lies in where the arrhythmia is propagating and how it is propagating. See, each of the drugs is going to have an impact on the electrical circuit, just in a different way, but they can all lead to the same universal outcome, terminating the rhythm. So in this video, I'm going to show you how SVT actually propagates with something called a reentrant rhythm. Then we'll manipulate the circuit and see what each treatment does to terminate the rhythm. And at the end, I'll show you my favorite way to terminate SVT, which apparently is not the one that most of you all like. If you've never seen these videos before, I'm Ryan. I'm an emergency medicine pharmacist, clinical toxicologist who works in ERs to help treat things like arrhythmias or poisoning. And I recently released a series on why we give magnesium in torsades that you guys really liked. So I thought I would make some more arrhythmia videos. So let's dive in. To understand how this arrhythmia propagates, we need to understand how the normal cardiac conduction system works. So quick review. We get electrical impulses starting at the SA node. It spreads its depolarizing wave to the AV node, and at the AV node, it sends the signal down each of the Purkinje fibers, which then go up the ventricles. So the AV node is the gatekeeper between the atria and the ventricles. And we know our QRS here is going to light up every time that signal hits the ventricles. But let's look a little bit closer. Let me take the AV node and blow it up. Let's imagine this is tissue in the AV node. Here I have signal coming from the atria, and every time it reaches here, that's the ventricle. So this is where we see a new QRS generated. QRS! QRS! And in SVT, we have a lot of QRSs, or ventricular depolarization. Something is making the ventricles depolarize too quickly, so I'm having too many heartbeats. And the thing that does that in SVT is called a reentrant rhythm, where instead of depolarization starting at the beginning of the AV node and moving to the ventricle, I get a depolarizing wave that propagates in the AV node itself around an area of non-conducting tissue. This is SVT. Every single time this wave hits this corner, that's a QRS. That's a ventricular depolarization. And as you can see, it's happening at a much faster rate than when we were getting normal conduction through the whole AV node. See, this is really slow. I'm bored. Here's a quick side-by-side comparison of normal conduction through the AV node on the top versus a reentrant SVT on the bottom, which you can see cranking out QRSs about twice as fast as your standard conduction. Feel free to rewind this video and watch each of them separately so you can get an idea of the pace. So reentrant rhythms are the propagation methods for most SVT. That's how the arrhythmia survives. You can actually have reentrant rhythms in multiple parts of the heart. If you're having it in the atrial myocardium, that's called a flutter. If you have it in the SA node, that's called SA nodal reentrant tachycardia. And if you have it in the AV node, that's called AV nodal reentrant tachycardia. Now, 60% of SVT is AV nodal reentrant tachycardia. And that's because arrhythmias only exist when the right depolarizing stimulus meets the right tissue conditions. They're honestly kind of rare and ephemeral and beautiful in a way. But the tissue conditions in the AV node predispose to SVT because you have 2 tracks of tissue, a fast track and a slow track. You can actually see the slow track right here. This part is taking longer to repolarize. And all you actually need for SVT is an area of unidirectional block, like these repolarizing tissues, and suddenly I can propagate a wave around. So because the tissue conditions in the AV node are more favorable, we just more often see it there. So let's talk about how to terminate this rhythm. Now, the first way to do this is through electrically depolarizing all of the cells at the same time. Yes, I did change my shirt. I will several times throughout the video. I do not record these all at once. But remember, this ephemeral wave, which is acting as our pacemaker because it's moving really fast, needs to find freshly depolarizable tissue each time it makes around this circuit. So if I make every cell refractory with electrical cardioversion, the wave terminates and our normal pacemaker can start again, putting us back into normal sinus rhythm. And of course, we can also do this pharmacologically with everyone's favorite drug, adenosine. And to clarify, this is a lot of healthcare workers' favorite drug to give because it's exciting and fun for learners to see, but it is never a patient's favorite drug to get, and that's why it is not my favorite drug. Here's an EKG. They're about to give adenosine, and you will see very soon that their heart is going to stop. Just not a fun feeling. Now, what adenosine is actually doing is opening up potassium channels in your automatic pacemaker cells of the heart. Remember, you have 2 types of tissue in your heart. You have contractile muscle cells, which make up 99% of the heart mass and do the physical pumping. And then 1% of your cells are your automatic pacemaker cells, like your SA node, AV node, Purkinje fibers. And very importantly, adenosine only works on pacemaker cells. Now, what adenosine is actually doing is opening up potassium channels in your heart cells so they can leak all of their potassium out. Okay, not all your potassium, but enough of it to hyperpolarize your cells. If you remember from our last video, we talked about action potentials. We're going to cover that super quick right now because there's something different about action potentials in the AV node that impacts how we treat it. So remember, your cells are polarized because you keep more positive charges outside the cell than in. You do that with this sodium-potassium ATPase pump that uses energy to pump sodium out and less potassium in. And when you stick an electrode in the cell membrane, you can measure the relative decreased positive charges in the cell compared to outside as a negative or negative 90 millivolts. That's our resting membrane potential. And if you are negative in the cell, it means you have a charge, so you are polarized. And if you're polarized, you can depolarize. Depolarization is what leads to all the second messengers that leads to cardiac contraction. In myocytes, we do this by flipping on sodium channels. And all that sodium we pumped out of the cell, it naturally wants to move across its gradient into the cell. So it floods into the cell. We get a bunch of positive charges moving in, go all the way up to about positive 10. This is a cardiac myocyte. It only opens up when it gets a signal from an automatic pacemaker cell. And it turns out pacemaker cells have different action potentials. They will automatically depolarize because they have leaky sodium channels. So sodium's constantly leaking in until we hit a threshold potential, at which point their depolarization is dependent on calcium. But they still repolarize based on potassium. So if I let excess potassium out, instead of being here, I might actually be down here to start, meaning it'll take longer to reach a threshold potential, and I can actually hyperpolarize all the tissues and prevent any heartbeats from happening. That's how adenosine works. This is going to come to play in one of our other talks. But hey, why can I only give adenosine if it is a regular rhythm? Well, it has to do with where the arrhythmia is propagating. You see, adenosine only works on nodal tissue. It makes the inside of automatic pacemaker cells hyperpolarized. It does not affect myocardium. Remember, SVT looks regular because it is moving around at a regular rate, producing QRSs at the exact same interval. If the AV node starts getting hit by randomly timed wavefronts by, say, fibrillating tissue behind the AV node, then the time between each QRS varies, creating an irregular rhythm. So now I have a fast, narrow rhythm, so it's SVT, but it's irregular. Like these QRSs, which seem to change intervals between each beat. This is another rhythm entirely. This is atrial fibrillation. And atrial fibrillation does not propagate in nodal tissue. It propagates in myocardium. It's disorganized depolarization within the atrial myocardium. And each time this disorganized rhythm hits the AV node, I get a QRS. Now, it can move really fast. I can see fast heart rhythms, but it's not the AV node causing the rhythm. It's the atrial myocardium. So if I turn off my automatic cells, this is still propagating in the background. And when my cells turn back on, they just keep receiving that malpropagating rhythm. Okay, what if you don't want to make your patient feel impending doom? Very kind of you. There is another, and I think much more sophisticated way to terminate this rhythm. Instead of making all the cells refractory at once, just make sure these ones become refractory for long enough that when all of these depolarizing cells reach them, it stops. And we have a few ways to increase our refractory time, like giving calcium channel blockers or beta. Remember, depolarization of nodal tissue is dependent on calcium. If I block calcium, it takes longer to depolarize, and thus I have a longer effective refractory period, prolonging the refractory period side by side. Beta blockers also reduce intracellular calcium and have functionally the same effect. And entire Cochrane reviews have been done showing calcium channel blockers are as effective as adenosine in terminating SVT, and you don't have to make them feel like they're going to die. Okay, the last method for terminating SVT through increasing refractory time is my favorite, the Vagal maneuver. Now, if you want to know how this actually terminates SVT, you need to understand some basic cardiovascular principles. And the thing you need to remember is that you are only able to live because of homeostasis, the process where living organisms regulate their internal environment. Negative feedback loops. And we have a lot of negative feedback cycles to regulate blood pressure. Just think about it. If your blood pressure is high and your body says, oh no, I'm going to respond to make it higher, your head would explode. And if your blood pressure was low and your body says, oh, I'm going to make it lower, you would die. So when your blood pressure is high, your body needs to respond by trying to lower it. And when your blood pressure is low, your body responds by trying to raise it, trying to maintain a normal, regulated blood pressure. Now, blood pressure itself is the shearing force between how tightly our blood vessels are squeezing the blood in them, we call that systemic vascular resistance, or SVR, and how much blood we're pumping through those tight vessels per unit time, which we call cardiac output. So your blood pressure is a product of how tightly you're squeezing and how much you're pushing through those tight vessels. And if one of these changes, like tightening our blood vessels, which increases our blood pressure, we'll need to change the other one in the opposite direction, in order to maintain a normal blood pressure. And this is where vagal reflexes come into play. Your AV node is normally innervated by the vagus nerve. However, it's not always sending signals. It's actually often blocked. There are signals saying, hey, do not send signals to the heart. But when your blood pressure in the thoracic cavity goes up very significantly, your body says, whoa, my blood pressure is too high, I need to lower it. So baroreceptors in the aortic arch detect that increase in blood pressure, and they send a signal to the brain saying, hey man, it's okay, let the vagus nerve do its job, it's time to slow things down. The vagus nerve then sprinkles acetylcholine onto the heart, and acetylcholine acts on a G-coupled protein receptor to open up potassium channels. Basically doing the same thing that adenosine did, causing hyperpolarization of those cells and slowing conduction. And thus my cells are refractory for longer and the rhythm terminates. So how can we increase our pressure in this thoracic space enough that the baroreceptors in the aortic arch trigger and tell the brain it's okay to slow down the AV node and reduce our cardiac output? Introducing the vagal maneuver, which I think is pretty cool. How many maneuvers do we actually get to do in healthcare? Agency, this is Mr. Control. Activate vagal maneuvers. Roger that, Mr. Control. Vagal maneuvers, engage. There are many different vagal maneuvers we use, but they all generally involve taking a big breath, filling our thoracic cavity with air so that the increased pressure presses on our blood vessels, and we detect that as an increase in vascular resistance, leading to an increased blood pressure. So we try to lower blood pressure by reducing cardiac output. One version is to plug your nose, take a deep breath, and blow out. Or we have patients take a deep breath and try to blow out a syringe, which is very hard to do. In some cases, we actually directly compress a blood vessel, which the body detects as a really big increase in systemic vascular resistance. So it tries to regulate blood pressure by decreasing cardiac output. You get the idea. This is called carotid massage. Now, vagal maneuvers are non-invasive. They can be very effective and they're very easy to do, but there's an even more sophisticated way where you can take advantage of two homeostatic feedback mechanisms to directly innervate the AV node with the vagus nerve. I told you I had a favorite way to convert SVT. Let's talk about how. We know that the body is trying to reduce cardiac output due to elevated systemic vascular resistance. Remember, cardiac output is equal to heart rate times stroke volume. So it could try to reduce cardiac output via stroke volume. So another way we can augment this is to rapidly increase stroke volume while we increase systemic vascular resistance. Then the only thing the body can do is drop our heart rate. And they actually did that in this awesome trial called the REVERT trial. They randomized people to just doing a regular Valsalva or doing a leg lift and then doing the Valsalva maneuver. Remember, Frank Starling says that our stroke volume is directly proportional with our preload. So when you do a leg lift, all that fluid in your legs rushes into your inferior vena cava, your preload spikes, and your body says, whoa, 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 my stroke volume is really high. I should bring my heart rate down to regulate cardiac output. And if you're massively increasing your systemic vascular resistance in that tiny thoracic cavity, well, now your body's saying, whoa, 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 I should shut down my cardiac output. So you get a 2-input negative feedback cycle, and that leads to a 43% success rate for vagal maneuvers compared to your standard approach. Okay, that was how SVT initiates and propagates. And I can only use adenosine to terminate SVTs when they are regular, because irregular SVTs are AFib that propagate through the myocardium. And how we can use our drugs to terminate the rhythm either by hyperpolarizing all the cells at once or by just making some of them refractory to terminate the somewhat ephemeral propagating wave within the reentrant rhythm. If you're a healthcare worker or maybe you're just someone learning about medicine, I hope you found this interesting and enjoyed learning about the why behind the interventions that we make. And I hope you feel more empowered to make a better decision about treating your patient's SVT in the future, or at least understanding why it is you're doing what you're doing. If you like these kind of videos, let me know. I'm happy to try to make more, and I hope that you enjoyed it. Okay, see you at the next Arrhythmia Pharmacology Case Review.